Hi everybody, Dr. Britt, Talley, Daniel, a neurologist and electromyographer and writer on carpal tunnel syndrome and blog writer. So the question for today is, how do you tell when you need to have surgery for carpal tunnel syndrome? And it's a tough question. It basically will relate to the fact that the usual treatment of carpal tunnel syndrome is conservative management, which is resting of the hand for usual activities and then splinting the hand at night or for any activity during the day that bothers the hand. Like if you drive a car and your hand gets numb and tingling, you could wear a splint during that time. So splinting should be done nocturnally for 1 to 2 months, or you splint the hand anytime during the day that the symptoms bother you. Although I've heard a lot of patients say it's really difficult to type on a computer or use 10-key punching if you got a carpal tunnel splinted on there. Now, the idea at the beginning should be, what's the cause of carpal tunnel syndrome? Well, it's the median nerve entrapment neuropathy at the wrist, right here at the wrist. And the median nerve is the main nerve that goes to the digits 1, 2, 3 in your hand. And it's the main nerve we use for feeling. If you're looking for change in your pocket and see if you got a quarter or a nickel, you use the median sensory fibers on the palm surface of your hand to make that determination. So, persons that get carpal tunnel syndrome, it's about 10% of the world population. And women have carpal tunnel syndrome 3 times more than men do, mainly because they have a smaller carpal tunnel. I'm going to use my fingers in a lot of kind of okay pinched area to indicate the carpal tunnel is this little circle and it's in your wrist. It's got bones on the back side here and it's got a little ligament on this side. There's a little tunnel in there. The median nerve goes through the tunnel. So persons who have carpal tunnel syndrome are born with a small tunnel, and that's one of the reasons they get it. And women have smaller carpal tunnels than men do. Also other things like overweight, puts a lot of fat around the nerve, it squashes the nerve, or diabetes, or rheumatoid arthritis, or previous fracture of the hand, the wrist area, which can cause scarring, and scarring around the nerve with healing can cause long-term symptoms of carpal tunnel. Those are risk factors for carpal tunnel syndrome develop. Okay, in general, persons who have carpal tunnel syndrome should be treated conservatively. Conservatively would be splinting the hand for a month or 2 and resting the hand as best you can, and quit aggravating type of activities that bug the hand and make you symptoms. The other thing you can do then, if you fail that after a couple of months, you can have a cortisone injection given into the wrist here 2 times, separated by a month. And the way the cortisone works is it shrinks nervous tissue. So it's found that the median nerve, which is in the carpal tunnel, when it's inflamed and the patient is symptomatic, the nerve is swollen. Just kind of like you sprain your ankle and your ankle gets blue and purple and it's so swollen you can't get your shoe on. The same kind of swelling occurs in your wrist with the median nerve. And cortisone shrinks the nerve so there's enough room in the tunnel so it doesn't press on it and compress it. All right. What would be the factors that would cause a patient when I consider surgery? Well, the doctor can help with this. First thing would just be patient's choice. If they have a job, cutting hair, doing data entry, some kind of work with 10-key or typing, and that aggravates their symptoms, it doesn't cause them, but it aggravates their symptoms, and they're going to lose their job, and they like their job and work there, then those persons should consider carpal tunnel surgery if they have failed a couple of months of conservative management with resting and splinting and cortisone injection. The other thing that can be a factor here would be how bad the pain is in the wrist. Carpal tunnel pain can be in the hand, the pain fibers here in the wrist, but they can be referred and it's the forearm and up in the shoulder. And they usually get better through therapy. If they don't, it can really hurt a lot. And the pain of this is really significant enough that some patients want to have surgery just because of the pain they're having in their hand. All right, the other factor would be the neurologic exam that the doctor sees. If he takes a little pin and he tests for pin perception over the palmar surfaces of the thumb, index, middle finger, which are the usual digits of the hand innervated by the median nerve, and you can't feel it. A lot of patients can't feel it there, can't feel it. Well, the pin will pick in down at the base of their finger. They can't feel it, and they've lost sensation for pin perception. And that's called a median sensory neuropathy, where the sensory fibers for pain have been involved. That's a consideration to think leading to surgery, because then you've lost the ability to feel, and that's a cumbersome thing. The other factor would be this: there's atrophy, which is wasting of the base of the hand thumb muscle here, the abductor pollicis brevis muscle, the muscle that closes the thumb to the little finger. So if that muscle is gone, that usually indicates long-standing carpal tunnel syndrome, and is a factor in consideration for considering surgery. And even though there is atrophy or pin sensitivity loss, surgery can improve those. All right, the next thing to consider would be the evaluation of an electromyogram test with nerve conduction studies and a needle exam to see how bad that is. And in general, an EMG can tell if there's mild, moderate, or severe carpal tunnel syndrome. Mild carpal tunnel syndrome is found when the median sensory fibers stimulating the palm or recording from the wrist as they go through the tunnel, if they're delayed. Normally, a value there should be 2.2 milliseconds. If it's longer than that, like 2.3 or 2.4, or if it's actually lost, you can get an ulnar nerve sensation, you get the radial nerve fine, but the median sensory nerve is gone. That's found with mild sensory findings on electromyography for carpal tunnel syndrome. Moderately severe carpal tunnel syndrome has the sensory findings as just mentioned, but also when you put a little electrode over the base of the thumb and you shock the wrist, there's a little twitch. If that period of time from the wrist to the thumb is over 4.4 milliseconds, which is a normal period of time it takes the nerve to get through that distance, if it's like 5, 6, or sometimes I have seen 10 or 11 milliseconds to get the conduction time from the wrist to the thumb, that's severe carpal tunnel syndrome. And so then you would have what's called moderately severe carpal tunnel syndrome. The sensory nerve and the motor nerve are both slowed or absent or delayed. And the final part to say severe carpal tunnel syndrome would be the doctor inserting a needle into the base of the thumb and the abductor pollicis brevis muscle here and seeing if there's what's called denervation, which is spontaneous firing of the muscle, indicating lack of connection between the motor fibers of the median nerve into the thumb base, and that's really severe carpal tunnel. So persons who have moderately severe or severe carpal tunnel on electromyography certainly should be consideration by a surgeon. The other thing is just the patient choice. Again, if there's a job you need to keep, if the pain is so bad, that's another thing you can do to consider that. And the patient has to really fail conservative management, which is first resting, splinting, cortisone injections a couple of months. Although sometimes I will see patients who are working, at a certain job and they just can't rest and they don't get better because they're continuously needing to use their hand, and there have been an acceleration of the process of them seeing a surgeon, have an opinion for that. So only 90% of patients with carpal tunnel syndrome are treated conservatively, and only about 10% need to have surgery. Yet the Mayo Clinic has said one of the most successful surgeries of all surgeries is surgery for carpal tunnel release, where the ligament is cut and the nerve is freed, and most of those people do really, really well. And I can testify to that myself because I had carpal tunnel syndrome chronically in my right hand, and I splinted for a long period of time, and my nurse in my office gave me 3 shots of cortisone on the wrist, and that helped for a month or 2, but then the symptoms came back, and finally I had surgery several years ago, and I'm just fine with that. Personal testimony. So good luck to you, all you patients who've had this problem with median nerve entrapment at the wrist called carpal tunnel syndrome, and I hope you do well.